Welcome to today's video. In this session, we'll be discussing the common drugs used to manage constipation during pregnancy, exploring their safety profiles and effectiveness. It's crucial to understand which treatments are not only effective but also safe for both the mother and the baby. We'll go over recommendations based on international clinical guidelines, including those from ICGs, ICGs, and evidence-based medicine. The major causes of constipation during pregnancy include 1. Hormonal changes. Elevated progesterone levels relax smooth muscles, including those in the gastrointestinal tract, which slows down bowel movements. 2. Uterine pressure. As the uterus grows, it can put pressure on the intestines, particularly in the later stages of pregnancy, which may contribute to constipation. 3. Reduced physical activity. Many pregnant women may experience reduced physical activity due to fatigue, discomfort, or other factors, which can slow intestinal motility. 4. Dietary changes. Changes in diet during pregnancy, such as reduced fiber intake or dehydration, can contribute to constipation. 5. Iron supplements. Iron supplements, commonly prescribed during pregnancy, are known to cause constipation as a side effect. Non-pharmacological treatments. 1. Dietary adjustments. A high-fiber diet, consisting of fruits, vegetables, and whole grains, is fundamental to managing constipation. Adequate fluid intake, 8-10 cups per day, is crucial for preventing and treating constipation. 2. Physical activity. Regular physical activity such as walking or swimming improves bowel motility. This is recommended as long as there are no contraindications. 3. Positioning and timing. Encouraging patients to respond promptly to the urge to defecate and sit on the toilet for several minutes after meals can improve bowel movement frequency and ease. Pharmacological treatments for constipation during pregnancy. First-line treatments. The medications of the first line that I will mention are safe during pregnancy and recommended by ICGs, ICGs, and evidence-based medicine. 1. Bulk-forming laxatives. Psyllium husk. Category A. Psyllium husk 500 mg. Dose 1 to 2 tablets taken 1 to 3 times daily. Psyllium husk is considered safe during pregnancy. It is a natural fiber supplement that works locally in the intestines and is not absorbed systemically. It is less likely to cause bloating than other fiber supplements, evidence-based medicine. It may be preferred by some women over Isbagula husk. Some guidelines ICGs do not emphasize its use as much as Isbagula husk, but evidence-based medicine supports its inclusion as a safe, natural alternative. Isbagula husk. Fibagel and Ispagel 1 sachet, 3.5 gram, dissolved in water, taken 1 to 2 times daily. A first-line treatment to increase stool bulk and stimulate peristalsis. It is safe during pregnancy and widely recommended for relieving constipation. Sterculia. Normacol 1-2 teaspoons, 6-12 gram, taken once or twice daily with plenty of water. A natural fiber that absorbs water and increases stool bulk. Considered safe and effective during pregnancy. Wheat bran. Bran 500 mg, start with 20-25 grams daily. Gradually increasing to 30 grams if tolerated. Which equals 4 to 5 capsules per daily. Promotes bowel movement by adding bulk to stools. It is safe but may cause bloating in some women. 2. Osmotic laxatives. Lactulose, Lacutose, Duflac, Isolax, and Cetilac. Initial dose. 3-6 teaspoons 15-30 milliliters once daily. Maintenance dose. 2-3 teaspoons 10-15 milliliters once or twice daily, as needed. A synthetic sugar that draws water into the bowel, softening stools. It is safe and widely used in pregnancy for constipation relief. Macrogol. Movicol. Dose. 1-3 sachets per day. Each sachet should be dissolved in 125 milliliters of water. Polyethylene glycol retains water in the stool and softens it. It is considered safe during pregnancy, though less extensively studied long-term compared to lactulose. Magnesium hydroxide. FDA Category A. Laxomag syrup. As a laxative, typically, 6 to 12 teaspoons 30-60 milliliters at bedtime. An osmotic laxative that draws water into the stool. Though not included in all guidelines, it is considered safe for short-term use during pregnancy, evidence-based medicine, particularly when other treatments are ineffective, but care should be taken to avoid diarrhea or electrolyte imbalances with overuse. Some oral medications, such as Mucogal, Epicogal, and Maalox, contain magnesium hydroxide and aluminum hydroxide, and their combination can be effective in treating constipation and heartburn, as magnesium acts as a laxative and counteracts the constipating effect of aluminum. 3. Stool softeners. Docusate sodium, FDA Category C. Ejicosate and Collis. Initial dose: 2-4 teaspoons 10-20 milliliters once daily. Maintenance dose: 1-2 teaspoons 5-10 milliliters once or twice daily, depending on the severity of constipation. Softens stools by increasing water and fat penetration. It is safe for use in pregnancy and effective for constipation relief. 4. Probiotics. Lactobacillus lacteal fort usually 1 to 2 capsules per day, and Bifidobacterium microbiota fit typically 1 capsule or sachet per day. Lactobacillus and Bifidobacterium strains may help regulate bowel movements and improve gut motility. While not universally recommended in all guidelines, evidence-based medicine supports their use as an adjunct to traditional treatments when other measures are insufficient. 4. Psychological factors. Stress and anxiety can exacerbate constipation. Cognitive behavioral therapy and mindfulness-based interventions may help alleviate constipation, particularly when dietary and physical activity adjustments alone are insufficient. Second-line treatments. 1. Stimulant laxatives. Senna FDA Category C. Senna Lax 12 mg, Pergatin 20 mg, starting dose: 15 mg once daily at bedtime. Maximum dose: 30 mg per day under medical supervision. Duration: short-term use only, 1-2 weeks. A natural stimulant that irritates the intestinal lining to promote bowel movements. It should be used cautiously and only for short periods due to the risk of dependence with long-term use. Bisacodyl, FDA Category C. Bicidal rectal suppository 10 mg. Dulcolax rectal suppository 10 mg. Menalax tablet 5 mg. Oral. The usual dose is 5 to 15 mg once daily, taken in the evening. Rectal. If using suppositories, the typical dose is 10 mg once daily. A stimulant laxative that induces peristalsis. It should be used with caution, especially in early pregnancy, and ideally as a last resort. 2. Lubricant laxatives. Glycerin suppositories. FDA Category C. Glycerin 1.47 mg rectal suppository. One suppository 2 to 3 grams is inserted into the rectum once a day, as needed. Glycerin suppositories soften stool, lubricate the rectum, and stimulate bowel movements by drawing water into the rectum by osmotic effect and mildly irritating the rectal lining. A safe option for short-term use when stools are soft but difficult to pass. It should not be relied upon long-term. Other treatment options. Prokinetic agent. FDA Category C. Prucalopride Constipride Pruca Soft Resolor Conistova and Mosapride. Not recommended during pregnancy due to insufficient safety data. It should be avoided, with a preference for safer alternatives such as bulk-forming and osmotic laxatives. Herbal remedies. Dandelion root. While herbal laxatives like dandelion root are sometimes used, there is insufficient evidence in the main guidelines to support their use during pregnancy. Evidence-based medicine suggests caution, as some herbal remedies may interact with other medications or have unstudied effects during pregnancy. Transcutaneous electrical nerve stimulation. There is some evidence supporting the use of transcutaneous electrical nerve stimulation for constipation relief. However, this treatment is not commonly recommended by the main obstetric guidelines. Evidence-based medicine suggests it may hold promise for future studies but cautions against widespread use due to limited evidence. Fecal impaction management. In cases of fecal impaction, more invasive measures such as manual evacuation or prescribed enemas may be necessary if other treatments fail. This should be handled under medical supervision, particularly in severe cases. Enemas. Saline or glycerin enemas may be necessary for severe constipation or fecal impaction when oral laxatives are ineffective. Cautionary notes. Iron-induced constipation. Iron supplementation, particularly ferrous sulfate, can worsen constipation. Adjusting the dose or switching to more bioavailable forms, ferrous gluconate or ferrous biglycinate, can alleviate this issue. Long-term laxative use. The prolonged use of osmotic or stimulant laxatives can lead to electrolyte imbalances and dependency. These should be reserved for short-term use only, with ongoing monitoring to prevent complications. Conclusion. Constipation during pregnancy requires a stepped approach starting with safe, first-line treatments like bulk forming and osmotic laxatives. Magnesium hydroxide and psyllium husk provide alternative options when traditional treatments are insufficient. Stimulant laxatives should be used cautiously, with short-term use only.